Thank you, Chris. I think when we cover healthcare and MedCity News, we rarely think of the logistics, but as precision medicine has been gaining ground, especially if you've heard of CAR T therapy, which is a kind of immunotherapy, you're taking a sample from the patient, bringing it back, re-engineering it, and then bringing it back to the patient. So it's even harder than Cologuard, I feel, because the right sample needs to get back to the right patient. Otherwise, that patient may not live. So I think logistics takes on a completely whole new meaning in the world of precision medicine. So thank you, Chris. Diabetes has become an epidemic in the US. Across the pond, I believe the situation is no better. So Dr. Naresh Kanumilli has been on the front lines of containing this expensive chronic disease in South Manchester.
Yeah, I'm trying to
So
put the
please
package
welcome
together
Dr.
for the company,
Kanumilli
but the
to the
capabilities
stage.
in UPS have been phenomenal. I mean, I've only been there 5 months, but the scale, they're not much of a...
Where were you before that?
GlaxoSmithKline.
Oh, right, okay.
Yeah, so I just moved back from London.
Thank you for staying
nice
back
to meet you.
and listening to somebody from across the
yeah?
pond. And we have another colleague of mine here as well, so 2 pond people coming across. So,
Would love to reach out. Drop me an email.
When I got this invite to do this talk, I didn't realize why I was here.
Solutions.
First of all, I thought it was a joke. And then I thought, well, actually, there are not many people with my name, my surname around the country, so it must be right. But I'm glad and humbled to be invited to be here, but I'm excited as well. So the couple of things I want to learn today was a couple of terminology as a doctor I never used: disruption. I don't know what that means until today. And then you talk about leverage.
And that's what
What's that mean? I don't know. So I'm learning lots of terminology that I wouldn't know as a doctor. So what I thought I would do is do a little bit about what's happening in Manchester. I think we talked about diabetes a lot. I think Chris has stolen my thunder. He's got all my slides, so I hope he gets lots more white hair, and in fact, I hope he becomes bald like me soon.
Yeah,
so I don't think I can run through the diabetes bit pretty easily.
So
what I thought was just talk about what's happening in Manchester. How many of you know where Manchester is?
If you come to Louisville,
Fantastic.
one of those warehouses.
Because over the last couple of days, I've been asking people asking where are you from, and I say I'm from England. I say, oh, London?
You know, we
not
do
London,
this
Manchester.
and we do
Where's
it well.
Manchester? I say, well,
we do their pick and
there.
pack process down to every single unit. If anybody ever gets prescribed,
in fact, the worst thing is my
type 1
parents also
diabetes
say, when I told them that I was going to England, they said, are you going to London? I said, no, I'm not going to London, I'm going to Manchester. London is the center of the world for everybody.
Well,
not right, it's Manchester. So how many of you know about Manchester as a city with 2 football clubs?
Expertise now over the years, and what I'm trying to do is bring
So you hope you get the pun on there, which says the city united,
we should be providing
city's
that
blue,
service for them.
United red. Yeah, the red half is the better half of the team.
So love to talk to you and get you.
So what is Greater Manchester?
See where we can help.
Manchester is just one city. Greater Manchester is made up of 10 regions. So we have a population of about 2.7 million. And we have 104,000 people unemployed, 112,000 presently on long-term sick and unwell. So 12,000 children are not school ready.
I'm probably talking a bit.
So there's a lot of things happening in Manchester that we need to be cognizant about. So one of the things is life expectancy at Manchester at birth. So you look at the males versus females, there's a gap of over 1.7 years and 1.8 years. If you look at healthy life expectancy, do people understand what healthy life expectancy is? You get to live until 59 years before you start developing disease.
I saw that you were a writer.
So that's 3.9 years worse off than the rest of England.
It's kind of a thing I do on the side.
So you can see we have a bad situation in that sense. And the other thing is you talked about zip code variation, we call it postcode variation. So if I told you that if you wanted 15 more hours in a day to live, move out of Manchester. So if you just move 10 miles, you lose 2.7 years of healthy life, just 10 miles from where I live. So Salford is one area where the demographics suggest that you won't live as healthy as you would in Bramall, which is 10 miles the other way. So health. So what is health? The ultimate source of any society's wealth is its people. Investing in their health is a wise choice in the best of times and an urgent necessity in the worst of times. So what makes us healthy? We've seen this before. So good work, surroundings. We heard Dan Burton talking about surroundings, Gil Palanosa talking about the parks and things like that. We're trying to do a lot of that in Manchester, but all these things are relevant because we always think about medication as the big thing. And what we're trying to do in Manchester is move from, we don't have a national health service. You must have heard of NHS, England, but we don't have a national health service anymore. We call it the National Sick Service. Because all we're doing is treating sick people. And I think medicine has gone from that. Actually, we were used to be treating sick people, but we moved from that to interfering with the healthy. We're trying to diagnose hypertension earlier. We need to do this earlier, pre-diabetes, diabetes, pre-diabetes, and where is it all going to end? So this thing kind of made me sit up and think of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. This is by Martin Luther King. So what are the challenges for innovation at a pace? These are all global issues. So increase in population, again, Chris mentioned all these things. Increase in over 85s population, funding deficit, all those things add to the issues around. Then what are the barriers? When you talk about Manchester and the NHS, the main thing seems to be about fragmented and slow decision making. There were so many structures, so much bureaucracy. So bureaucracy is actually a killer of innovation in the NHS. People come up with brilliant ideas, but the moment you start talking to CCGs, there's lots of things you have to put in place to try and get through. So people give up in the end. Structures who do not assist collaboration and coordination, lengthy and uncertain routes for adoption, excellent initiatives in one locality are not shared across the system, and we heard that many times across here in this conference. And industry finding multiplicity of organizations, initiatives confusing and add to risk. So what do you do about this? So my take on this has always been, first of all, you have to decide whether you're happy. So here's a small flow chart. So are you happy? Yes. Keep doing whatever you're doing. If you're not happy, and you want to be happy, well, do something different then. But if you don't want to be happy, keep doing the same thing again. So use this, put it on your wall chart, and then you think, well, actually, that might make me think differently about things. So Manchester decided that, the government in England decided that, okay, let's see what Manchester can do. Let's give them the money. So Manchester is one of the first devolved areas in the UK. So they said, here's £6 billion, and we're going to transfer everything to you guys. You manage health and social care in Manchester. So decision-making powers transfer to regional level. More decisions about Greater Manchester made here. So we're trying to go on the theme of our decisions about me, by me, for me, rather than somebody else making the decisions for you. And provide the means and opportunity to do things differently to meet the needs of our residents. So one of the things we found in the NHS in the UK is you get lots of diktats from central government, but they do not necessarily match the needs of the locals. So there's always been a bit of a conflict about what do we do for our population and where do we find the funding. So at least now they said, well, here's the money, just go and do what but we want some results, obviously. So it drives integration. So our objectives are transform the health and social care system to help more people stay well. Align our health and social care system with wider public services, such as education, skills, working and housing. So we're trying to look at it at the front end, trying to make sure education is there, works, get people back into work, and improve their skills, look at the housing, how we can make, going back to all the stuff that Gil Pellon also talked about parks. How do you get people cycling more? Talked about Copenhagen having 46% something about cyclists, getting it up to 50%. And he was talking about how to make it safer for cycling. We're trying to do all that. Have you heard of Chris Boardman, cyclist, Tour de France? So he's helping Manchester with trying to develop cycle paths. Create a financially balanced system and sustainable system, and make sure our services are clinically safe throughout. So there are 5 reasons to be excited about devolution. I'd say 6, because I come from Manchester as well. Single decision-making system. So no more running around different organizations trying to say, how can we do this? And social model of care implemented at neighborhood level. So we're not doing it at citywide level, but each neighborhood. We're looking at models of care which suit that area. So where I live in South Manchester, close by, there's a place called Wythenshawe where there's high incidence of teenage pregnancies. So talking about stuff like drugs and everything doesn't make much difference. What we need to do is how do we tackle teenage pregnancies and how do we support them? Integrated plans for key conditions like cancer, mental health, diabetes, medicines management, population health. Digital interoperability and innovation hubs, and evidence-based agile transformation methodology. Again, I can see this is all technology terms that, as a doctor, you try and struggle to get used to. So 3 major opportunities in Manchester. The future of healthcare and medicine will be, I'm not going to read all that, but what it's saying is the development of health data analytics using integrated big data sets. So again, Manchester has a whole digital organization that's looking actively at digital health, collecting data and using that effectively to develop pathways. A new approach to industry. Manchester is, again, one of the few areas that signed a memorandum of understanding with pharmaceutical partners so they can bring their pipeline of innovation and to rapid adoption. This does not happen in NHS because one of the things in the NHS is pharma are generally considered to be the evil half. And lots of GPs don't want to engage with pharma because they feel that they're actually using it to make money. So obviously, pharma has to make money, but I think there is a duty, a collaboration that we have to have with pharma because actually they provide a lot of money into research. New business models again. So what did Manchester do? So to try and make it easy for people to come into Manchester and invest, we developed what's called the Health Innovation System. As you can see, we managed to get all the industry together, academia and research, commissioners, and national and government agencies together. So you don't have to go to each one of those separately. You just go straight to Health Innovation Manchester. If you go straight to Health Innovation Manchester, they'll look at discovering, developing, and delivering. It makes it so straightforward now. So I'd like all of you to come to Manchester and invest. Now, when you talk to GP colleagues and looking at all the structure, they say, well, what does it all mean to me? What do you mean it's a bit muddy? So working collaboratively to move best value, not just best practice. So how does this relate to things that I'm actually passionate about? My passion is diabetes, and like Scott, I always have a personal story. 10 years ago, my wife was diagnosed with diabetes, and that happened while I was at a diabetes conference in America. She rings me and says, Naresh, I can't get off the toilet seat. I said, what do you mean you can't get off the toilet seat? I said, I'm struggling to get up. I said, well, come on, move. So I get back home, and then I go to work, and then she rings me, she's gone for a bath. I said, what are you doing having a bath in the middle of the day? You should be working or doing something. So I can't get out of the bath. So there's something really wrong here. So I went back, and actually, if you heard of proximal myopathy, so muscles become weak. So she was not able to get herself out of the bath and things like that. So I had to go back and help her about that. And when you checked her blood sugar, it was 26, so straight to hospital, insulin, and all the shebang. Now, the other thing that happened during that time is I have a daughter who's quite severely autistic as well. So a lot of the care for her is taken care, my wife does the care. So I have a son who also rings me every so often and says, Mum's acting weird. And I said, what do you mean Mum's acting weird? He said, well, actually, she's shouting at me. I said, well, you must have done something wrong. No, it's not really wrong. So I said, okay, fine, just go there and just check her blood sugar. So she was having hypos. Now, nobody, including me, who supposedly knows about diabetes, bothered to teach my son how to identify hypos. So that caused a lot of problems. And you think, well, actually, if it's happening in a family like mine, what's happening with the rest of the community? You know, what are we doing about education? What are we doing about trying to make sure that diabetes is well managed? And diabetes, as we know, is not an emotive subject. So if you had a heart attack or a chest pain, you'd go to the doctor straight away. If you had a raised blood sugar, would you go to the doctor? No, you don't. How do you make diabetes more emotive? That's the question. So I do a cardiology clinic. There are no DNAs in the cardiology clinic. DNAs do not arrive. But diabetes clinic, 20-30% DNAs, because they don't take it seriously. And I think one of the reasons is we healthcare physicians are probably to blame, because diabetes is easy to diagnose and can be managed with negligent ease by those inclined to do so. So what is diabetes? If you tell them it's a bit of sugar. Now that's not telling the whole story. A bit of sugar doesn't mean that you're not taking it seriously. So we talked about some of the facts, and these are mainly the facts about UK. So 10 million more adults, this is globally I'm talking about, 10 million more adults with diabetes in 2015, 34 million more adults at risk of developing. So these are figures that you've seen. For me, what's striking is over 1 million children and adolescents have type 1 diabetes. And 1 in 6 live births have hypoglycemia. Now, we know about all the other things about the people with diabetes, the type 2 diabetes and everything, but how many of us actually pay attention when a young mother with diabetes comes in and talk about pregnancy planning, preconception advice, all those things? We don't do that. So those are the things we're trying to build into the system in Manchester, trying to tell people, actually, you need to think every time somebody's in front of you with diabetes, what is going to happen in the future? It's a huge and growing problem. Now, Chris again put some data up there. One of the interesting things, if you look at it, is Middle East and North Africa. The increase is expected to be 110%. 110%. UK is not doing so badly, but still, again, we expect it to rise dramatically. And one thing we found was, again, going back to Gil Pelanoso's talk about what's called urbanization of diabetes. Have you heard this term? More people in urban areas are getting diabetes. There was a Canadian study that they did a thing where they moved people to a new development outside, which is fancy development, nice houses, everything. But they had to drive 10 miles to the shops. So they were using the cars more, whereas previously they were living in the city and walking around. So all that urbanization is happening, and that's causing more problems. Diabetes age, again, in 2017, there are 327 million people aged 20 to 64. In 2045, you're going to have 438 million. So one thing good about that is I'm never going to be out of a job. So the current picture, here are some numbers, 24,000. This is the UK. 24,000 people with diabetes die prematurely each year because of ineffective management. Now that is criminal, I would say. Is ineffective management, that's the part of me as a clinician, not talking about diabetes, as making it as important and emotive to the patient itself. Only 49% of people with diabetes receive all the basic tests. 80% of all costs for diabetes are on complications. Now, in the UK, we spend 10 billion on diabetes. 80% of that is in complications. And 1 in 5 achieve recommended levels for blood glucose, blood pressure, and cholesterol. 1 in 5. So without these simple checks, there's an increased risk of developing complications. Again, you look at lives lost. So a person with diabetes, whether they have vascular disease or not, they still lose 6 years earlier. They die 6 years earlier than a person without diabetes. We talked about this financial burden, but diabetes, huge and growing global problem. 4 out of 5 diabetes live in low and middle income countries. How many of you heard of Vilfredo Pareto? You heard of him? He's an Italian economist who actually theorized that a society would grow wealthy to the extent that its members forfeited general knowledge in favor of individual ability in narrowly constricted fields. This was what happening with management of diabetes. So people were in silos. So if you came to see me in primary care, I'd do these tests. But if you went to secondary care, I'd just do your glucose levels because they tend to be very glucocentric in secondary care. But what happens is the perverse incentives that have been developed about primary care gets paid for doing certain tests. Secondary care doesn't get paid. So if you went to secondary care, the consultant there wouldn't do those tests because he's not getting paid for them. Well, who's suffering in the middle? The patient is suffering in the middle. Because he's dropping in the middle because all he's going to the hospital is getting his glucose managed. He's not coming to primary care because we think the hospital is managing him. And then he just loses. That's where the complications arise. So in Greater Manchester, we're doing not too bad actually, but there is improvement needed in the annual health checks and achieving all 3 targets. The 3 targets that we talked about are blood pressure, lipids, and HbA1c. So those are three main things that we need to control, because most people with diabetes die of what? Any ideas? What do they die of mainly? Do they die of raised blood sugar? No. They die of cardiovascular disease. They all die of heart attacks. So we looked at what is called variation in care. This is difficult to see, but what I'll just point out is this is called a DOVE tool. So this is diabetes outcomes versus expenditure tool. So what we look at is you need to be in that cordon there, which is low expenditure, high outcomes. This place, this city or the town is right at the bottom there, so it's either spending a lot of money and having very poor outcomes. What we want to try and do is move that person from there to there. Now, the reason we find that variation is either because, one, the healthcare professionals are not knowledgeable enough, they're not using therapies that are suitable for the patient, and not using therapies appropriately and in a timely fashion. You heard of inertia, clinical inertia? So in England, so let's go, if you talk about a HbA1c, you get diagnosed and everything, you put you on medication. It takes about 2 years before another therapy is added, 2 years. And it takes until the HbA1c goes up to 9% before somebody does something. 9%. Now, your normal HbA1c, I'd expect you to have it between 6.5 and 7%. Now, you're waiting until it gets to 9. So by that time, we talked about retinopathy again, all those complications. You get neuropathy, nephropathy, and you're just going downhill. So what do we do in Greater Manchester? So we thought, actually, this top-down approach is not working. So let's look at how we do something about this. The only way you're going to do anything about any non-communicable disease is to engage with the population. Now, first thing first is one of the things we decided was we don't want to call them patients. We want to call them persons with diabetes, because we want to keep a holistic approach to them. We want to look at mental health, social health, everything, not just say blood pressure, cholesterol, and lipids. So those things are not what we want to focus on. We want to focus on the whole person. So we brought out a document called Language Matters, which is available online, and that kind of changed the discussion of the consultations between the person with diabetes and the healthcare professional. So we brought out a document called Tackling Diabetes Together. Again, this is available online. I won't go through this. The main premise of this was that we wanted to get the views of persons with diabetes. So it was built on talking to people in Greater Manchester and making a document that we could use as the guidance. So what we've done is, this came out earlier this year, and so we gave it to all the local communities and the hospitals and the general practitioners and said, this is best practice and this is what your patients or your persons with diabetes want. So we're going to come back to you in a year's time and you're going to have to tell us what you've achieved towards these targets that are in there. The big mantra that we decided was no medication without education. So we used a strapline, saying, well, no medication without education. So we all know that unless you explain to the person with diabetes why they're taking the tablet, what is it going to do to them, what are the side effects, they will not take it. 50% adherence, non-adherence we heard yesterday, 50%. So you're spending money on medication. In the UK, if the moment you get onto metformin, your prescription is free. But if I keep prescribing you medication without you taking it, it's costing the NHS money. It's not costing you anything, but it's costing you in complications. So we are trying to say, well, actually, we want to empower the person with diabetes to turn around to the clinician and say, well, actually, why? Why do you want me to take this? Tell me about the drug. I'll take it. We want to do more around that. Then we developed another thing. So this is where we talk about a little bit of collaboration between the partners, pharmaceutical companies, and everything. So there were 2 landmark trials that came out recently. One is called the EMPA regulation trial, and the other one is called LEADER trial. So these are 2 trials that were based on therapies that, if used in appropriate patients, would reduce your chances of getting cardiovascular disease and reduce your chances of being hospitalized by about 36%. Now we thought, well, actually, a lot of the guidance tells you these drugs cannot be used second line. They will say use it third line, fourth line. But by then it's too late. The evidence shows that you have to use it after the first drug, after metformin, which is the first line therapy. So we decided that we'll work with the pharmaceutical companies and patients and voluntary agencies and say, well, actually, we want a pathway that actually teaches with simple algorithms about what to do after you diagnose a person with diabetes. If they have cardiovascular disease, you need to use these drugs. Now, funnily enough, 2 days after we published it, the ADA and the EASD brought out the guideline, which kind of, they stole my guideline. So in a way, what I'm trying to say, I've not got many slides to go. So a lot of it, what we're doing in Manchester is basic stuff, but I think we decided that we go work from bottom up, but make it all a team work. So we want to keep the team together. So we're developing a Greater Manchester network, diabetes network, which has persons with diabetes on it, which has voluntary organizations, mental health teams, everybody. It's a multidisciplinary group that gets together and looks at evidence without having to worry about bureaucracy and things like that. I'll leave you with the last quote, which we use. If you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forward. Thank you.